that gets going, I'll start. Okay, like I said, I'd like to start this webinar by saying this activity is being recorded. Hello, everyone. Thank you for joining today's webinar, Understanding Prediabetes. My name is Phil Meir. I am the program manager with the American Nurses Association in New York. As stated previously, this webinar is being recorded and the recording will be listed on our YouTube channel probably tomorrow morning. Today's speaker will be presenting on the topic of prediabetes. So without further ado, I'd like to welcome Dr. Renee Murray-Bachmann.
Hello, everybody. Okay, so we're going to go over a couple of things. And the computer is going, there we go. So what are we going to discuss today? Well, we're going to discuss prediabetes mellitus, the importance of type 2 diabetes delay, and nutrition, and its impact on diabetes mellitus type 2 delay. So a long time ago, when I was a little nard and I was brand new to the field, before many of your parents were born, we used to say to our patients, you have a little bit of sugar. So we would notice an elevated blood glucose and say, you have a little bit of sugar. And we would also say you are on the borderline. So this funny little sign was up there on the borderline of Brooklyn and Queens. It's indicative of you're a borderline. And then we would also tell our patients, watch what you eat. So, you ever heard of the expression, the eyes are bigger than the stomach? Well, in this case, this is symbolic. Those eyes are bigger than the stomach. Well, now we know how the body's system works. So let's go over this picture together. And for those of you who've never seen it, if you just remember this picture alone, you will be able to tell your patients what happens with high blood sugar and low blood sugar. So let's start. High blood sugar. Let's just say our patient went out and ate 12 cupcakes from Baked by Melissa, and their blood sugar went up. So that elevated blood sugar or blood glucose will promote the release of insulin from the pancreas. Just follow the red arrow around. And this insulin would stimulate glucose uptake from the blood. We used to have a candy called Now or Later that we used to eat when we were kids. Well, this is like Now or Later. The insulin will allow some of the glucose to get into the body's tissue cells for now, and it will also stimulate glycogen formation in the liver. Consequently, the blood glucose level will go down. Let's look at the green arrow. Our blood glucose level is low. So consequently, it will promote glucagon from the alpha cells of the pancreas. And this glucagon will go to the liver and break down those glycogen stores, and we'll get some glucose, and the blood glucose will be raised. And this is an amazing thing right here. But what happens is when you're living with diabetes or even pre-diabetes, this very nice mechanism goes helter-skelter. So what exactly is pre-diabetes then? So it encompasses conventional diagnostic categories. Impaired fasting glucose, blood glucose is too high in the morning, it's elevated, or impaired glucose tolerance. After they eat, the blood glucose levels cannot normalize. These levels are high, but they're not high enough to be considered type 2 diabetes. So insulin resistance and defective glucose sensing at the beta cells, now those beta cells are the ones in the pancreas, they're the ones that produce the insulin, are the determinants that together cause hyperglycemia. So we've got resistance, the body will not use insulin, and defective glucose sensing at the beta cells, so not enough insulin is coming from these beta cells, and this causes hyperglycemia. So regardless as to where the insulin resistance comes from, Excessive tissue fat utilization is a consistent metabolic mechanism. So we may have some genetics that affect our beta cell function, but when we become overweight, that is the main challenge to insulin action. And prediabetes includes elevated elevated blood lipids or the dyslipidemia and a higher arterial blood pressure. So you see where this is going. You may have been told, and you may know from your studies and from your practice, that prediabetes and diabetes type 2 are cardiovascular risk. So at any given time, your plasma glucose concentration represents a balance between glucose into and exit from the circulation via the cellular mechanism, metabolism, or excretion. Now, what happens is that glucose in, glucose out are subject to regulatory mechanism. Remember that first slide I showed you with the green and the red arrows? Okay, insulin and glucagon, which are like each other's antagonists, are controlling the entry and the insulin governing exit. And the pathophysiology of prediabetes just comes down to this. Is glucose release abnormal? If so, is it because the beta cells or the alpha cells are not working properly? Is the glucose disposal abnormal? Is it because the beta cells are not working properly? Are they not giving us enough insulin? Or there are changes in insulin sensitivity? In other words, do we have any insulin resistance there? So pre-diabetes encompasses conventional diagnostic categories. In other words, we're looking at two things with pre-diabetes. We're looking at impaired fasting glucose. And this occurs when the fasting blood glucose levels, that means no caloric take for at least 8 hours, is greater than 100 milligrams per deciliter and less than or equal to 126 milligrams per deciliter. Let me say that again right. It's when the fasting glucose is greater than or equal to 100 milligrams per deciliter and less than or equal to 126 milligrams per deciliter. Now that's the fasting. Then there's the impaired glucose tolerance. If that is greater than or equal to 140, but less than or equal to 199 in a 2-hour sample, that's considered impaired glucose tolerance. So that's after eating, that's postprandial. So again, insulin resistance at the level of the liver and the tissues and the defective glucose sensing at the beta cells, which means we're not getting any insulin, are basically what's coming together as a triad to predict high blood sugar or hyperglycemia. So regardless as to what's going on, here it is, and that's why I put it in big, bold letters. Becoming overweight is a main challenge to insulin action. It also includes, along with that overweight, elevated blood lipids or dyslipidemia and higher arterial blood pressure. Again, which is why we're at increased risk for cardiovascular sequelae. So who has prediabetes? Well, let's look at some numbers from the CDC. 96 million people age 18 years or older have prediabetes. Well, that's 38% of the US adult population. For those 65 years or older, 26.4 million people, or 48.8%, have prediabetes. And what we've noticed here in this chart from the CDC is that if you look at prediabetes estimates in percentage, this are the estimates of people who have, the percentage of folks who have it, but look at the awareness. The awareness significantly drops. So they may be walking around with this and not even know it. They're not diagnosed as yet. And this is across the board. Actually, our Asian brothers and sisters aren't doing as bad as the rest of us. So about 1/3 of US adults had prediabetes over the entire period. And if you notice, the people or the percentage that were where they had it has increased. So what does that tell you? Those numbers are going up. So screening. Screening should begin at age 35. Testing for prediabetes, that impaired fasting blood glucose, that impaired glucose tolerance, or any type 2 diabetes in asymptomatic people should be considered in adults of any age with overweight or obesity. So that's a BMI of 25 kilograms or higher per meter squared, or higher in the general population, but it should be initiate a screening in Asian Americans who have a BMI of 23 kilograms per meter squared and who have one or more risk factors, but we'll get to that. So this is an informal assessment and can be done in asymptomatic adults, and risk screening should be done also in children. Those children who have a BMI at the 85th percentile or obesity, I like to use the term extreme overweight in the childhood, in the pediatric population, of the 95th percentile and who have one or more risk factors. Also, people with HIV should be screened for diabetes and pre-diabetes with a fasting glucose test before starting their antiretroviral therapy. At the time of switching their antiretroviral therapy and 36 months after starting or switching. If the initial results are normal, fasting glucose should be checked annually. Colleagues, for those of us who have worked with patients living with HIV, we have been noticing quite a number of them who have been on antiretrovirals who are developing type 2 diabetes. It could be the insulin resistance, so that is why you want to assure that this population is screened. Okay, so to screen for prediabetes and type 2, you can do a fasting plasma glucose. You can do a 2-hour plasma glucose during a 75-gram oral glucose tolerance test, or you can do the A1C. The A1C should not be done in populations with hemoglobinopathies, such as anemia, sickle cell anemia, because it's not going to be active. Okay. When using an oral glucose tolerance test as a screening for diabetes, adequate carbohydrate intake, at least 150 grams per day, should be assured for 3 days prior to testing, but we'll get to the carbohydrate intake. So if tests are normal, screening should be repeated at a minimum of 3-year intervals, sooner with symptoms or change in risk. Remember, we talked about that overweight? If your patients are starting to gain weight, that is an opportune time to repeat the screening. And of course, in prediabetes as well as type 2, they need to identify and treat cardiovascular disease risk factors. We'll get to that, but we were already discussing the dyslipidemia and the hypertension. So I wanted to share these tables with you directly from my absolute favorite book. Every year I look for this in December, and it's the Standards of Medical Care in Diabetes. Comes out every year for January 1, comes right out at the end of December. And this is the 2002 diabetes care. So look for it. Comes out every year, Standards of Medical Care in Diabetes. And you can go on to the ADA website, diabetes.org, and look under professionals and look under journals and education, and you can find diabetes care and look up for the standards. It's free.
So let's go over our criteria together as indicated by the annual standards. So for asymptomatic adults, we talked about the BMI. We're also going to look for those with a first-degree relative with diabetes, mom, dad, brothers, or sisters. We're going to look in patients with a high-risk ethnicity population, African American, Latino, or when I say African American, that could be anybody who is Black, Latino, Native American, Asian American, Pacific Islanders, and I like to throw my own one in there for good measure, and I always say New Yorkers, because we are the ones who end up with our Seamless and our Uber Eats and our Grubhub, and we're eating and eating, and if we're not going to the gym or at least walking around enjoying the sights, we are becoming more and more overweight. Any patient with a history of cardiovascular disease, any patient with a low HDL cholesterol level, which is less than 35 milligrams per deciliter, that's our protective cholesterol, and or a triglyceride level greater than 250 milligrams per deciliter. Women with polycystic ovarian disease or polycystic ovarian syndrome, those who has physical inactivity, those are those couch potatoes, those folks who can sit back and watch the Yankees and shout instructions from the couch, but never get up and get some exercise. There are other clinical conditions associated with insulin resistance. Again, the severe overweight or obesity and acanthus nigricans, which is a darkened area, and you can see it on the back of your patient's neck or sometime under their arms. So patients with prediabetes, which is an A1C greater than equal to 5.7%, but I will also put here less than 6.4%. Patients with the IGT, impaired glucose tolerance, or impaired fasting glucose, well, these should be tested yearly. Women who were diagnosed with gestational diabetes or who had baby greater than or equal to 9 pounds should have lifelong testing at least every 3 years. Gestational diabetes is that extreme insulin resistance associated with pregnancy, usually after the 26th week of pregnancy. I always tell my colleagues working in labor and delivery, if she comes in there in the first trimester with elevated blood glucose, you don't have someone with gestational diabetes. You've got a woman living with diabetes who is pregnant. That is different. But gestational diabetes is known for its extreme insulin resistance, and consequently, those people or those ladies are at risk for developing type 2. For all other patients, testing should begin at 35 years. 35 years, this is the big one. 35 years, there is nothing wrong with being tested at 35 years and going forward, because you can get the A1C test if there's no hemoglobinopathies present at your routine physical, and the A1C does not require you to come in fasting. If results are normal, testing should be repeated at a minimum of 3-year intervals. And of course, we mentioned our patients with HIV. So this is a screening for type 2 or prediabetes in asymptomatic children and adolescents in the clinical setting. Again, our overweight adolescents, those whose mom had diabetes or gestational diabetes, a family history of type 2 in mom or dad, brother or sisters, all of our lovely ethnicities, and I always like to throw in there New Yorkers, because there's a McDonald's and a Popeye's fried chicken on every corner down here in New York, and our kids really do eat out a lot, and they're overweight. So signs of insulin resistance or conditions associated with the resistance: the acanthus, the hypertension, the dyslipidemia, the polycystic ovarian syndrome, or even a child with small for gestational age birth weight. That is also an indicator for insulin resistance. Were they small for gestational age?
as a child or as an infant, definitely they need to be tested. So here's our criteria defining pre-diabetes. Fasting blood glucose between the 100 and 125, or the 2-hour postprandial glucose 75-gram oral glucose tolerance test, 140 to 199, or that A1C between 5.7 and 6.4, but not in the presence of hemoglobinopathies. If your patient has anemia, sickle cell disease, or even if your patient has CKD, we would not rely on the A1C test for defining prediabetes. But remember that 5.7 to that 6.4 under normal circumstances. So here it is again. You notice that I am very redundant. I always teach like that so it sticks in. There's your pre-diabetes, 5.7 to 6.4. Once you hit 6.5 or higher, you're type 2. Fasting blood glucose between 100 and 125. Once you hit 126 or higher, you're a type 2. 2-hour glucose after 75 grams of glucose, 140 to 199. Once you hit greater than 200, type 2. And any classic symptoms. So what are the classic symptoms? You probably remember them. Polyuria. I always tell my patients that's like weeing like a racehorse. Polydipsia. Drinking like a racehorse. Polyphagia. Eating like a racehorse. Any of those symptoms, and blood glucose greater than or equal to 200. You know that's probably got a type 2 on it. So this is a really cool test from the American Diabetes Association, a very good screening test, and you can go right to their website and download it. This is the baby of the ADA and the Centers for Disease Control, and they can take this test. For every indicator here, you get a certain amount of points. So say, for example, your patient was between 50 and 59, they get 2 points there. Are you a man or a woman? If you're a man, you get a point for that. If you're a woman, have you ever been diagnosed with gestational diabetes? Well, yes, I have. You get a point for that. Do you have a mother, that first-line relative? Yes, you get a point for that. Have you been diagnosed with high blood pressure? You get a point for that. Are you physically active, or are you shouting instructions from the couch? No, you get a point for that. And what is your weight category? And we go and do the height for weight. And if your total scores are 5 or higher, you're at risk and you need to talk to your LMP about that. Or in the case of all of us, they need to talk to us about that. And we'll collaborate with their licensed medical provider toward a plan of care. So we went over those risk factors. Again, I am always redundant when it comes to that. Even though the risk factors for prediabetes and diabetes, all individuals more than 45, what do we say? Screening should begin at around 35. Again, there are cardiovascular risk factors because both prediabetes and type 2 are risk factors for any cardiovascular disease. We're going to look to this. Overweight, in addition to overweight, do they have a blood pressure greater than or equal to 140/90, or are they on therapy for hypertension, any antihypertensives? Do they have an elevated dyslipidemia, elevated fasting triglycerides? That should say greater than 250. I don't know how that less than got in there. And do we have low density lipoproteins? Okay, a low density lipoprotein, low high density lipoprotein. The HDL is the one that's protective. If it's low or less than 35, then we have a problem. So just to go over this again, hypertension greater than or equal to 140/90, or on therapy or on an antihypertensive, that's a risk factor. It mentally turn that sign around. Dyslipidemia, elevated fasting triglycerides greater than 250, and low HDL. That's going to be less than 35. All right. All of these are risk factors. And again, I'd like to remind you, certain medications will make the patient at risk for living with prediabetes or diabetes, and they are antipsychotics, antiretrovirals, such as our patients living with HIV, okay, glucocorticoids, our diuretics, our beta blockers, and our statins. All of these, if your patient is on them, they are at risk for prediabetes. Please screen them, because the prediabetes is definitely the risk for the type 2. Now, along with the impaired fasting glucose and impaired glucose tolerance, we need to remember that these are symptoms, but they are not a diagnosis unto themselves, okay? You're also going to check for your cardiovascular risk when you see these. So we've gotten past the pre. We're just going to touch on the type 2 for 2 seconds. In type 2 diabetes, there exists excessive hepatic glucose production. In other words, there is unnecessary release of glucose into the bloodstream from the liver. That plus, because I do love a math problem, plus decreased peripheral glucose production. In other words, you're going to get your resistance there, and that's going to equal an elevated hyperglycemia, elevated fasting hyperglycemia. All right. So if my rapid first phase of insulin secretion is decreased or absent, in other words, I'm eating and nothing's happening from my beta cells, plus I've got glucagon secretion from my alpha cells. I really don't need that to happen right now, but it's happening. And then I'm going to end up with postprandial hyperglycemia. So this is going to be giving me elevated blood glucose. No insulin, but I've got glucagon. I'm going to get postprandial hyperglycemia. Too much glucose coming from the liver, resistance, I'm going to get fasting hyperglycemia. And here's a little picture of my favorite slice of pancreas. And you can see these are my beta cells. They produce insulin and amylin. And there's my alpha cells, and they produce glucagon. And each one of them produces a hormone that has opposite action than the other. Insulin and amylin is going to come from the beta cells. Glucagon is going to come from the alpha cells. So, insulin resistance. Type 2 is associated with, I made this nice and big, overweight and insulin resistance, and the latter of which, this insulin resistance, is both genetic and environmental. So what happens with insulin resistance? So we feel tired and hungry, we eat bad carbs. We'll get to the carbs. We make some insulin. Cells won't use the insulin. Sugar stores as fat. We feel tired and hungry. We eat bad carbs. And here we go around and around and around and around in a vicious cycle. We end up with that intra-abdominal overweight or obesity, which causes insulin resistance. We've got our increased hepatic triglycerides. We talked about that. What's our number? Greater than 250. And we have increased plasma-free fatty acid concentration. One thing about diabetes, it's progressive and treatment must be intensified over time. Okay, I'm sure that you heard about cytokines, especially when we were discussing COVID about a couple of years ago. Well, so what are the cytokines? They're the small proteins that assist in controlling the growth and activity of immune system cells and also blood cells. So they work on our immune and inflammatory responses, and they're key modulators of inflammation. Colleagues, when you have inflammation, you get insulin resistance. So here's my little adipocyte, and here's my little adipokines, and I'm going to let you look at those. All right. Resistant. It increases insulin resistance. Think of its name, resistant. What's it's doing? It's resisting, and it increases inflammation, and we get obese, and we have obesity. Leptin. Leptin is going to decrease insulin sensitivity. It's going to decrease hunger, but it's going to increase inflammation. Where you get inflammation, you have diabetes and atherosclerosis. Visfatin, decrease the plasma glucose and decreases inflammation. Oh, that's kind of nice. I'm going to move this out of the way so that I can see. Okay. And then, of course, we have adiponectin, and that's going to increase insulin sensitivity, but it's going to decrease inflammation. So again, a couple of my favorites to look at are leptin. It's going to decrease insulin sensitivity, decrease hunger, but it's going to increase inflammation. You're going to get all these slides. So these are things in which you can use to remind yourself, or put it in, translate it from medicalese and talk to your patients about it. So we want to prevent our type 2 diabetes. We're going to talk about the nutrition, but studies have shown that lifestyle interventions, which include, here's my math question, diet plus, should I say my math example here, diet plus exercise equals weight reduction. And this leads to a relative risk for the progression to diabetes mellitus from prediabetes. And evidence has shown that the above changes can cut the risk for diabetes mellitus development by 1/2, according to Damon et al. So let's look at the diet. That's what we all came for. And some of my favorite colleagues, Everett et al., were discussing that 87% of patients living with diabetes mellitus are overweight. Let's go back to that. 87% of patients living with diabetes mellitus are overweight, and 63% are obese. However, even a small weight loss of 5% will improve glycemic control. So look at it, 87% of people living with diabetes are overweight, but even a small weight loss of 5% will improve the glycemic control, those blood glucose levels. And I talked about myself here. Approximately 40 years ago, I would have provided a diet that patients would prefer death rather than attempt. Yes, those diets pulled all the fruit out of them. They had nothing but complex carbohydrates, and those were limited, and it was horrific. We now know the diet must take into consideration the amount of carbohydrates consumed, and it must be individualized. We need their medical history, their diabetes self-management level, and how we need to teach them, their present health behaviors, where they want to be, their health literacy, what they understand, and the emotional response to diabetes, as well as their culture. So, body weight and energy balance. So we need a balance here. The energy intake for body weight, normalization, and maintenance after weight loss, we want to do that BMI of less than 25, or if we're Asian American, less than 23. All right. We need an energy reduction and fat reduction for those that are overweight or obese. All right. We know that a decrease of insulin resistance will happen with a moderate weight loss. So to begin with, either a low fat or low carbohydrate calorie restricted diet may be effective, but only in the short term. Okay. Our chemical energy, our carbohydrates, fats, and others. See our nice meal there. And that transfers, that glucose breaks down. We have ATP, energy currency, into our metabolism, and it gives off heat and our chemical waste. And I'm sure you remember that from your science courses. So carbohydrates, when we're working with our patients toward a nice balanced diet, and this is by colleagues Everett et al. In Diabetes Care, I highly recommend that you check them out. And I'm going to, when this is left behind, I will leave these references. Carbohydrates should be 45 to 60% of the total calories, okay? Carbohydrate counting, exchange, or experience-based estimates remain the key strategy for control, but we'll get to that. Carbohydrate counting is something wherein we know how much insulin we will take. We use this with our patients who are injecting insulin, and they're going to cover the amount of carbohydrate they eat with insulin. And we say, okay, for example, you're going to have 1 unit of insulin. I'm throwing a number out there for every 15 grams of carbohydrate that you eat. So quite naturally, they have to count their carbohydrates to know that. So carbohydrate, okay, and how did that come in there fast? That was a mistake. Please forgive. A1C, blood glucose, and serum lipids indicate the most appropriate carbohydrate quantity within the range. So in other words, colleagues, even though we're using 45 to 60 grams of total daily energy, we still have to monitor our blood glucose levels. We're going to be looking for those serum lipids because that's a cardiovascular risk. And we're going to be looking at the A1C, assuming that our patient has, hemoglobinopathies or issues with CKD. Dietary fiber. It's ideally around 40 grams per day, soluble and insoluble. All right. Foods naturally rich in dietary fiber are recommended. And examples of solitary dietary fiber are vegetables and fruits, and insoluble are dietary fibers such as whole grain products. However, if you end up with a patient such as I had the other day with Crohn's disease, you know that they have problems with that insoluble dietary fiber. So you're going to go more for soluble for them. All right. Again, dietary fiber is ideally 40 grams per day. Soluble and insoluble, a nice balance. Dietary fiber minimum is 14 grams for every 1,000 kilocalories per day. For diabetes prevention, I tell you plainly, fiber is really great because it stops the body from absorbing that glucose so readily. I'm sure you've heard of this, the glycemic index. Glycemic index is a ranking system for foods based on their blood glucose level impact. And glycemic load is the amount of carbohydrates in a portion of food together with how quickly it raises blood glucose levels. So here's some examples. You know it's high glycemic index when you have your sodas and your cookies and your candies. Medium are your, you see some fibers here, some fruits, and low glycemic index are some of these fruits here. Now, if something is a high glycemic index, what's going to happen? It's going to cause the blood glucose levels to peak, and they're going to shoot up quickly. Whereas if it's a low glycemic index, they're not going to peak as high. Then there's glycemic load, and it's the amount of carbohydrate in a portion of food together with how quickly it raises your blood glucose level. So let's look at some foods. I'm just going to throw some things out there. All right. For example, we talked about high glycemic index. Well, there is our sodas. Let's even pick a Gatorade. So Gatorade has a high glycemic index, but its glycemic load is only about 12. However, go ahead and drink a gallon of Gatorade and see what will happen. It's going to go up even higher. All right? That's what happens. The use of glycemic index and glycemic load may provide a modest additional benefit. But what I'm going to do is I would like to share with everybody who's come a list of glycemic index and glycemic load for about 100 foods that we use quite readily. And you may find it interesting when working with your patients. Oh, the sugar. Sucrose and other free sugar-containing foods can be substituted for carbohydrates at a maximum of 10% for total daily energy. So this looks like somebody hit up the Dunkin' right there. That is what they have to watch. Oils of all kinds. Fat intake, maximum 35% of total daily energy. And a saturated fat should be restricted to less than 7% of the total caloric intake. I remember the other day I was having this discussion with some of my patients about fat in filet mignon. They didn't realize that it's a saturated fat meat because they really couldn't see the fat the same way they could on, say, another cut of steak. And I'm letting them know, yes, that tenderness is due to the saturated fat in that particular cut of meat. Trans fat, you're going to find that in hardened hydrogenated fat or oil. Monounsaturated fat, 10 to 20% of total daily energy. Olive oil, grapeseed oil, avocado, and nuts. However, fats are still, colleagues, 9 kilocalories per gram. 9 kilocalories per gram. So even though it may be heart healthy, it still is going to make them gain weight if they do not watch their portioning. All right. Polyunsaturated fat, omega-6 should not exceed 10% of total daily energy. So you can find that safflower oil, sunflower oil, flaxseed. And then, of course, there is our omega-3 unsaturated fatty acids that we find in our fatty fish like salmon, and also in grapeseed oil, soybean oil, or nuts. Cholesterol intake should be less than 300 milligrams per day and ideally less than 200 milligrams per day if LDL and cardiovascular risk is raised, okay? Where you're going to find a lot of cholesterol that some of my patients just absolutely love is in the yolk of an egg. And then they want to eat 3-4 eggs a day. So you see where that's going. Protein. Protein should be between 10 and 20% per day. However, if the patient is going on a diet, you don't want them to have more than 20%. Again, more than 20%. If they want to do weight loss, no more than 20%. You see them, I'm going on this high protein, low carb diet, and they're creating stuff and they're eating meat all day long. Well, that's not recommended if they want to lose weight. So we're going to restrict them to restrict patients who have nephropathy to about 0.8 to 1 gram per kilogram of body weight per day. So that's a different type of patient. A patient may be living with diabetes but have nephropathy. For our patients who don't, we're going to remind them, no, we're not going to do more than 20% of total daily energy because we do not want them to start gaining weight as opposed to losing it. Alcohol. I brought this up because my patients ask about it all the time. Oh, yes, especially when the family member comes. We drink wine at a meal every night. Can they drink wine? And if you tell them, well, they're going on this type of medication now, maybe just to start, they shouldn't have that. And then they ask you 20 minutes later and then another half hour later. Well, with regards to alcohol, a moderate intake of 10 grams a day for women and 20 grams a day for men is tolerable. That means that half of that little wine glass they can have. If there is no contraindication, that's 1 drink per day or less for women and 2 drinks a day for less than men. If they're pregnant, they should not be drinking. If they have a history of alcohol abuse, they should not be drinking. Personally, I don't like my patients that have any medication that's acting at the site of their liver, such as metformin on alcohol, but to reduce the risk of nocturnal hypoglycemia in individuals using insulin or insulin secretagogues, such as a sulfonylurea like glimepiride or glipizide. Alcohol should be consumed with the food. So in other words, if they're going to have that half a glass of wine with the meal every night, that's when they're going to have it with the meal. Supplements. And most of my colleagues and the references prefer to choose foods that are naturally rich in antioxidants, vitamins, and minerals. Okay? Chromium supplements are really not recommended. So a lot of folks say to me, well, why is that, Renee? Well, studies have shown that chromium supplementation does not effectively improve glycemic control. And that's from several meta-analyses. It did not improve the fasting plasma glucose levels. And unfortunately, there are no clinically relevant chromium effects on body weight that are available. And there are no reliable methods to estimate chromium status. So presently, it cannot be recommended. And then routine supplementation when those antioxidant tablets is not recommended. Okay, because little support due to trials from these pills can be shown. You can get all these antioxidants from the vegetables and the other foods that you eat. And also, I'm going to put this as an aside. Colleagues, many of these things, these supplements are not FDA approved. We really don't know what dose they should be taking, and so we do not want our patients, many of which who may have comorbidities, to take these pills or over-the-counter meds. So specific functional foods for diabetes. Renee, what is that? I'm sure you've heard about it. We're going to drink some apple cider vinegar and that'll lower our blood sugar. We're going to have some soybeans and that is going to lower our fasting blood sugar. And we're going to drink all the cinnamon and it's going to help our postprandial blood glucose. And these things are delicious, but there is no real evidence according to the studies. And I was looking at Hamasaki et al., excellent reference, which I will include, that shows that soybeans have no effect on fasting blood glucose, and cinnamon has no effect on postprandial blood glucose. It's delicious. But again, soybeans, no effect on fasting blood glucose according to the studies and the meta-analysis, and cinnamon, no effect on postprandial blood glucose. So you really don't need to go out to have the patients go out of their way to include these foods unless they just like the taste. My absolute favorite, this is what I love to give out. The plate method, I'm sure you know of it. It's so much easier. A lot of times, and earlier we discussed about 10 grams of this, 20 grams of this, this percent, that percent. But when you're dealing with a patient who is pre-diabetic and you want them to try to avoid rolling over into being a type 2, and you want them to avoid that weight gain, basically, here it goes. Half the plate is non-starchy vegetables. 1/4 of the plate are carbohydrate-containing foods. Personally, I love a potato, a rice, pasta. Corn is not a vegetable. Please remind your patients that you're simply not a vegetable. And then, of course, your protein foods, meat, lean meat, chicken, or fish. And of course, water or a 0-calorie drink. And this type of portion works very well with regards to maintaining a good weight, maybe even losing that 5% of weight to get better blood glucose control. And it's easy, this concept is easy for them to use if they're eating out as well. Okay. Are there any questions before we have our little test?
If you have any questions, feel free to put them in the chat and I'll read them to Dr. Renee.